At the end of the day, the only task of personalized medicine, the way how I understand it is, that you have a person, patient or consumer, and you just want to know what does the general health status. We have it in our cars. Our cars have check lights. And so basically, the problem we solve is just to connect this. We are able, out of a blood sample, to generate a snapshot of the health status of the patient at that time. It's a dynamic snapshot. Here's our sample report. It's called the General Metabolic Program, and I will explain what this is, but without any jargon. So what we see is very basic. It's a human, and there are different health areas like inflammation or pancreas or kidney are pretty well-known ones, right? And then we have a traffic light system: green, yellow, orange. This is the first product, and it helps solving many problems.
Welcome to Beyond the Blueprint, a podcast designed to empower healthcare professionals, enabling them to improve care delivery through integrated design and technology innovation. My name is Greg Malkery, and joining me is my co-host Keith Washington. Whether you're redesigning a hospital, launching a new digital initiative, or just curious about the future of healthcare, then you're in the right place. Let's explore together what's possible when we go beyond the blueprint. Today we'll be exploring personalized medicine and how emerging technologies can be used to treat illness, help transform how we care for patients. To help us break this down, we're thrilled to welcome Dr. Ali Tinazli, CEO of Lifespin. Lifespin is a technology company attempting to make healthcare more personal, accurate, and accessible. Ali, welcome to our webinar. Before we dive in, perhaps you can tell us a little bit about yourself and your journey that led you to focus on personalized medicine.
Hey, good morning, gentlemen. Good morning, Greg. Hey, Keith. My journey started actually when I was 15 years old. I was watching a documentary on German broadcast television about molecular medicine and what the promises are of biochemistry and molecular biology in the diagnosis and treatment of diseases. And then this got my spark, because until then I didn't really know what I want to do. But then since this moment, I got really this spark and passion for health technologies in a wider sense. So this made me decide to study biochemistry and graduate in biophysics actually with my PhD. And then right after my PhD, I concluded in order to do something useful, I think I got into corporate world. And many people may hate me for that when I say this, but I think if you really solve a problem and people are willing to pay money for it, then you really solve the problem. This was my thesis, why I left academia and joined basic corporate world. I was at ABI in tech scouting, in licensing. Then I moved over to Sony, built a new business at Sony, scaled from 7 people to 120 employees. And then I got an email from HP. 2 weeks later, I signed up my contract, so to say. So I joined HP as a global head of healthcare strategy located at Palo Alto in the CTO office. And the task at HP was to look at the corporate assets. We have a bunch of technology. How can you make it really work in healthcare? And this was a really interesting moment for me, because I got a bunch of smart MBAs and we diced and sliced the worldwide healthcare market to understand what does a new healthcare solution need to deliver to be accepted. And the answer is, it's not the technology alone. It's the packaging, and most importantly, it's the affordability. And only we're blessed, I think, as we sit here, that we are in this upper 20% or 25% of world population which has access to really good healthcare. And most people don't, right? And to understand the drivers, and then also to understand that there are lots of monies to be unlocked if you do it right. This is something which is really fascinating, right? It's not only about the technology, it's about how to make it available, how to address the first mile, how to get the patient or the consumer into the system. But yeah, so that's basically my journey. So I've been working on problems and challenges all my life. I like to solve challenges and have uncertainty, because this makes things exciting.
Great. Thank you, Ali. Hey, Keith, do you have any opening remarks for today?
Yeah, Greg, maybe just for folks that might be new to Beyond the Blueprint, we look to bring together thought leaders exploring new innovation in design and technology to help manage complexity in hospitals and health systems that are really looking to enhance patient care. We see how good design can not only align organizations with their core mission, but also really promote collaboration and offer platforms with insight to help navigate the change in technology as we move forward. So a lot of that is to try to become more patient-centered. I think this topic today is very much about that. I'm really excited to hear about this new technology and how it kind of might fit into future design opportunities, operational opportunities, and really designing for what I like to think of as the post-epic world. So thanks again. I'm looking forward to it.
Great. Thank you, Keith. Now, before we dive into today's discussion, I want to recognize our valued sponsors who've made Beyond the Blueprint possible, Storage Systems and Simplify Medical. With their support, we're able to bring you insightful conversations around healthcare design and innovation. If you enjoyed today's show, I encourage you to subscribe so you never miss a future episode. Hey, Ali, to kickstart, let's talk about, doctors often struggle with how to find diseases early, keep costs down, and give each patient special care. Can you talk about the main problems that Lifespin is attempting to solve, and why does it matter today?
We all know the situation that we have with certain conditions or our loved ones. If a symptom, we go to a physician, and the physician don't really know what's going on. So you don't feel well, and then you get one test or another. You're still hanging for a couple of weeks, and either it goes away by itself, or it persists, or worsens. So basically, we are dealing here with unspecific symptoms of complex diseases, right? What are unspecific symptoms of complex diseases? Could be an inflammation signal. It could be the onset of diabetes, or it could be the onset of a liver or kidney condition, which is at the beginning very vague. And the physician, with today's standard of care tools, is used to prescribe one test at a time. But the issue is, when you have unspecific symptoms, you don't know what you really should look after. So basically, it's a guesswork. And what is missing today is a comprehensive systemic snapshot of the health status of an individual. And basically, we talk about personalized medicine. It sounds perhaps very fancy. At the end of the day, the only task of personalized medicine, how I understand it, is that you have a person, patient or consumer, and you just want to know what is the general health status. We have it in our cars. Our cars have check lights. Do you need to replace oil? Do you need gas? The automotive industry figured it out. We have not figured it out in healthcare, which is actually hard to believe, right? And so basically, the problem we solve is, just to connect this, we are able, out of a blood sample, to generate a snapshot of the health status of the patient at that time. It's a dynamic snapshot, but this enables basically the physician and also the patient to see if things are in good shape or not. And actually, I can show you this. Here's our sample report. It's called the General Metabolic Program, and I will explain also what this is, but without any jargon, so right from the tech. What we see is very basic. It's a human, and there are different health areas, like inflammation or pancreas or kidney are pretty well-known ones, right? And then we have a traffic light system, green, yellow, orange. This is the first product, and it helps solving many problems. I will also say two things. First, in order to get this type of information with standard of care, you have to order at Mayo Clinic or LabCorp all the tests they have, pay hundreds of thousands of dollars to get this type of information. And it's not sustainable, right? Most people wouldn't be able to afford it, and it would take a long time. What we do is we take a blood sample, we then look at the metabolome. So what is the metabolome? We are all living beings. All living beings have plethora of biochemical reactions. These reactions have small molecules as intermediate compounds. And just to keep it simple, we all live, we eat something, we eat sugar, it's getting metabolized into different other molecules, which basically is our metabolic profile. And if someone has a certain condition, there are shifts in the biochemical pathways. For example, if you drive on 101, there's traffic in the morning, traffic all the time actually, and then you go to 280, less traffic. So basically you try to find some bypasses, right? Same thing happens in our body, right? There's one pathway clogged up for different reasons, and then the body tries to compensate it, which then causes a change of concentration of different molecules. And that's basically what we figure out. That's what we measure.
I like that example of the check engine light, right? Because I've had the check engine light come up, and it doesn't tell you anything, right? I just know something's wrong. I go to the dealership and they can make anything they want up, but having increased diagnostics makes all the difference in the world. So when I look at lifespin, you guys are using some advanced tools, artificial intelligence, nuclear magnetic resonance to improve healthcare. Can you explain in layman's terms how this technology works and why it's better than traditional methods like blood tests?
So, first of all, when people hear these technical terms, they may get scared, right? Maybe AI or nuclear magnetic resonance, right? Some technical. Let's break it down. First of all, when you, for example, get an accident, you get a torn ligament or broken leg, then we get an MRT, right? It's an MRI image. That means we get scanned in a tube in a strong magnetic field. So I think this method is relatable to everyone, to physicians and to patients at the same time. Now think of the very same method, but instead of a 3 Tesla magnet, you have a 13 Tesla magnet. So Tesla describes the magnetic field strength. We basically take a much stronger magnet, and instead of making images of body parts, we make, well, physically spoken, images of molecules. How does this work? Now, first of all, it's a purely physical method. In a magnetic field, you have electrical properties of molecules which differ from each other. And this is well described. So this method actually was invented in 1945, and it has been mainly used until now in the chemical industry and in the pharma industry. So it's not a new method per se. New is to use this method to deploy it in healthcare as a clinical tool. When it comes to AI, AI has different shades, right? There's generative AI, but the very basic AI, it's even not AI, is statistical analysis. You look at something, you count how often you see it. That's the very basic foundation of a software, of an analytical software program. And then you, of course, then run different clinical trials, studies. You start comparing different patients to each other, and then you start probing advanced algorithms which are smarter than non-advanced algorithms, and then you land at AI. I think it's important to see that AI actually just an advanced algorithm. We have AI everywhere, right? Cars have AI. They can recognize road conditions to compensate the suspension, right? That's all. That's why I think it's even not too much about the AI aspect. It's about the combination of different aspects together.
Let's make this a little bit more real. Can you share a story about a patient who might have benefited from using lifespin's technology and how it made a difference in their health?
Yes. So, for example, we can determine in blood samples lipid profiles. So the advanced lipid profiles, lipoprotein particles. These lipoprotein particles are very important because if the size of these particles are small, then they tend to increase the risk for cardiovascular diseases. In worst case, it could be heart attack, it could be stroke. If you don't know about it, you cannot do something about it. Now, in order to access this information that you actually have this potential issue with your lipid profile, you would have to use methods which are not covered as standard of care. It's more specialty diagnostics. So basically, you would have to pay hundreds of dollars to get the information about your lipoprotein particle size and numbers. In our case, this information comes as part of the package. So basically, when you look at our health report, you open page 13, and I just make it very explicit because it's a real example. You open page 13, and then you have here a chapter about lipoproteins. And this basically shows you the distribution of the particle sizes, the number of the sizes, and this basically is an early warning sign for the development of cardiovascular disease. Now, if you have this knowledge, then you can proactively speak to a physician about it. And then they will say, okay, statins, and then problem solved. Right? Statins today are generics, very cheap, even in the US, but the information, what's missing in today's healthcare is the access to information on a personal level, that I really have this condition, or I have the risk of developing this condition, so I should do something about it. For example, when 20 years ago, we got the step counters, right? At the beginning, some tech geeks used step counters. Once I found one in a taxi, I was quite amused, like, what the heck is this? But now you find step counters everywhere, in watches, in phones, and you can do something about it because you know that you make only 2,000 steps in today's office life. And same applies to these metrics, like lipoprotein profile. Where should I have been able to get this information before? Unless I request it from my physician, But for this, I need to know about it. That means it excludes the average person. In our case, with the overview, the dashboard, the traffic light, you see that something here is cardiovascular. You see that something may be coming up with your cardiovascular score. So you basically start proactively this dialogue with your physician. Then the physician says, it's true. Let's put you on statins. Problem solved. And so that's why our innovation is not that we invent some new fabulous biomarkers or that we make very new statements. Our innovation is that we extract this information layer, which is hidden in blood, and make it affordably available for routine care.
Ali, is this technology ready for prime time? And what are the current adoption levels of personalized medicine in the U.S.? Are we seeing any changing in protocols from the different disciplines that might be focused on cardiac conditions, cancer, etc.? So where are we today? Now, certainly the term personalized medicine has been around for 2 or 3 decades.
Yes.
But is it ready for prime time now?
First of all, I would say, although I use it myself, personalized medicine actually is medicine for everyone, right? Step 1. Step 2 is, what are our societal challenges when it comes to healthcare? Challenge 1 is, because of unhealthy lifestyles, we get into non-communicable disease pandemics, right? Like obesity, diabetes, chronic kidney disease, liver conditions, NASH, MASH, name it, right? This is the huge burden. That's the healthcare crisis we are in. The other crisis is technology solutions are getting more expensive, right? When you look at the challenges with healthcare insurances, not only in the US, so I lived in numerous countries and each country has its own issue. So basically the healthcare cost inflation or the explosion is tremendous. So basically when you get hospitalized once, for many people it can be an existential crisis because it's just way too expensive. And that's why when you have the solution, which does the job on the prevention side. So basically, if you alter your lifestyle just a little bit to avoid the onset of a chronic condition like cardiovascular conditions, like diabetes, for example, then you can save so many healthcare dollars.
Well, it does seem to me that as we look at this whole concept of population health, which may not even be the term anymore, that personalized medicine is a key component of that in order to better manage larger populations in a more unique way, depending upon the individual patient. Is this stuff being utilized today in the United States? Or are we seeing more traction in more international domains? What is the current state of affairs?
About is personalized care the other side of the medal of population health? Definitely yes. Population health broken to N of one person. The second is, what's the status of these type of healthcare solutions? When it comes to lipoprotein profiles, you can order these tests, for example, at Mayo Clinic, at Webcore. Just to be explicit, they offer this, right? So basically all great healthy institutions are knowledgeable and they offer this. However, it's not part of the standard package. You have to pay a premium, right? So today it's more situated in the specialty diagnostics, which also goes hand in hand with awareness when it comes to cardiologists. For example, I have the privilege of speaking to, let's say, cutting-edge cardiologists who are very aware of these solutions and basically want to use these solutions on their patients, which then comes to the next question of the availability. You see now personalized medicine, especially the way how we base it on metabolomics, is an emerging field. So basically you find this in the top hospitals worldwide. So you find this at hotspots in the US. Mayo Clinic, of course, is always part of this innovation, cutting edge. But you see this also at other top-notch health institutions in Asia Pacific and in Europe. But it's still at the early onset. So it's comparable a bit to next-gen sequencing. 15 years ago, you may recall the big news of the Angelina Jolie in breast cancer genetic test in 2011, 2012. And that's basically when NGS became better awareness in mainstream. And now you find an NGS as part of every lab offering, right? So it takes some time. Important prerequisite for this mass adoption is basically awareness. For example, we are working right now on determining the insulin resistance score, which again is today located in specialty diagnostics and it's not standardized. But then when I did some literature research, I found an article in the World magazine, March 24. I was pleasantly surprised to find an article about the insulin resistance score in the World magazine, right? That was amazing, which tells me the market is right to accept these new healthcare innovations. Now it's a matter of finding the right market channels. For us, that means to find the right B2B partners to basically bring it to patients, because the biggest challenge in health tech is not to make the tech work. The biggest challenge is how to reach the first mile, how to get the patient, how to get the consumer into the system. So basically how to get the patient sample incorporated into the system.
How's this technology being clinically and financially demonstrated to be effective, right? So are insurance companies paying for these emerging tests? Or maybe there's other places in the world, right, where they see the adoption, maybe in Asia Pac, right? Where are we today in terms of the health system adopting this and healthcare organizations actually embracing it as a new standard of care?
What I'm seeing, and it's always a very subjective view, obviously, is that private healthcare providers or basic providers and private payer systems have, let's say, the largest degree of freedom to adopt new technologies because of more relaxed regulation, and at the same time, because of increased willingness of patients or consumers to pay for these services. So basically, I see the first adoption uptake in private healthcare settings worldwide.
My final question before I'm going to hand it off to Keith, what's the next step for Lifespin? Where do you hope to be over the next 12 to 18 months in terms of the penetration of your technology, how this might get more widely adopted in specific geographies? What is your vision?
So we are now in the midst of discussions with B2B and B2B2C partners. So basically, these are healthcare organizations, hospital or large hospital chains, for the pharma companies, to basically adopt this technology, bring it to market, and make it acquainted to average consumers or patients. And I mention consumers because patients who are not sick are consumers, just to look at it from the other angle, right? So basically, this is where we are. There is another question which I didn't answer yet. You asked me in your previous question about the cost effectiveness and what we bring onto the table from a healthcare economics perspective. Now, the cost to analyze patient sample, to analyze a blood sample, is basically in the lower double-digit dollar range. So basically, I used to show in my presentations a pizza margarita to say, look, that's the cost of the scalability. Now, the price is always a matter of specific terms and conditions, but I'm very open with this structure because I want to achieve mass adoption in checkup medicine, in preventive care. And that's why it's better to have a business which is affordable, or it's better to have a product which is affordable, can be paid by everyone, even as out of pocket, because healthcare insurances motivate and incentivize also their clients to spend more out of pocket for preventive care solutions. So we had basically meetings in the past with the innovation teams of healthcare insurance. So basically incentivizing healthcare insurance clients or just consumers basically to do more, but it must be affordable. And the issue of today's, let's say, especially diagnostics, maybe genomics, transcriptomics, proteomics, is it's too expensive for routine use. And that's something we want to change.
Great. Thank you, Ali.
Economics, in terms of, if you look at the saved healthcare dollars, if you can prevent diabetes or if you can prevent liver conditions, right? That's obvious.
Thank you, Ali. Keith, do you have any questions you'd like to ask Ali?
Yeah, thanks. Thanks, Greg. Thanks, Ali. Yeah, a couple things that are really fun. Nikola Tesla is one of my heroes. I love the technology. I love all the things he did. But also I love the fact that your background's in chemistry. Also, I got my undergrad in chemistry. In college I was using NMR. It's like, I love it. Chemistry, we know, Ali, that's the universal science. Everything eventually becomes a chemical problem, right? The ohms and volts and all the measurements of electricity, those aren't like, you can't see those. You can't weigh those. We all know chemistry is where it's all at, right? So that's my worldview. I love that.
I have biophysics to read too. So physics actually is the queen. If chemistry is the king, physics is the queen.
Perfect. I love it. I love that. So then I guess I want to explore a few things with you on some of the things you said. So do you feel like cardiology is really one of the best use cases for your tech? Or I guess tell me a little bit about that. If you're just kind of entering kind of a new opportunity or just kind of framing where you're going to get the most benefit short term. With that, am I getting that right, or did I?
So when you look at the deployment of our technology solution in preventive care and in checkup medicine, then the key areas are cardiology, diabetes, prediabetes, and liver. These are the key areas. The way how we basically develop our algorithms are in a way that the thresholds we are setting in our traffic light system from green to yellow to red is as following. Making a statement if someone is healthy or red is trivial, very easy. Important is to select the right threshold from the transition green to yellow, because it must be early enough that you can still do something about it to turn it back into green, right? So basically, It's really about the smart adjustment of the thresholds, which is a matter of basically our digitized proprietary biobank and our mathematical models to achieve that. But as my recent example, last week I got tested on Friday. I did it for bronchitis. Not sure if I mentioned this earlier, but basically, as our system shows also inflammation, I was expecting that basically my inflammation traffic light should be at least yellow. I was already on antibiotics, but then I was expecting that it should be not green, definitely. It showed up as red, which was very pleasing, because I was saying, okay, I'm still not feeling okay. It's totally fine that it's red, because red means go and seek a physician. Yellow means keep watching. So when I get tested again next week, I should have yellow or perhaps even already back green. So that's the dynamic nature of what we do. So basically, the system provides actual results, which on one hand encourages patients or consumers to do really something about their health. And second is, because it gives you this dynamic answer, it incentivizes to get tested again. So basically, if you get useful information, you like to do it again, right? If it's just superficial and common sense, like drink more water and do exercise, no one would pay for this test ever again. But if you really have this dynamic testing, which responds to your actual lifestyle, this is very interesting.
That's what, because you had mentioned how obesity, sedentary lifestyle is also like a comorbidity across all these conditions. So this stoplight chart you have, the yellow, green, red, gives the patient information, really valuable information to kind of understand when they might need to seek, get the advice from their doctor or do something more aggressive. But otherwise, it'll give you that kind of confidence, at least to know like what your current status is, I guess. So if your current go-to-market is to go through mostly health systems and hospitals, what do you think about trying to go direct to consumer? Have you looked at that angle, or?
Yes, we're actually in discussions with health organizations, which are also setting up a DTC business. Setting up a DTC business requires lots of good planning, because you will get questions from consumers which you have to answer. Basically, you need to have a certain infrastructure to be able to literally support the patients or the consumers with their legitimate questions. Because, for example, a few weeks ago, I did have a guest in my company, and his pancreas showed actually yellow. His glucose values have been very, very high. And then I told him, look, you should really watch out with your health. But then he got instant questions. Why? What can it be? And it shows that you need this, at least, optionality to speak to someone. It's very, very important. And that's why we are right now in the stage where we have completed the platform. Now it's ready to launch. And that's why we support now, of course, our B2B partners, which have interest in deploying this in a direct-to-consumer testing setting. We are also ready for that from a platform standpoint, but doing it ourselves would require basically a very different planning, which we are open for the future. But right now, it's more important for us to have this also in a curated fashion in terms of having it in the hands of healthcare providers. Because what you also need to do is you need to build credibility in the market. So I used to work at big brand companies like ABI, Sony, HP. They get instant credibility, but when you work in a startup, you have zero credibility at the beginning. Just your own personal credibility is something you can weigh in, but beyond that, you have to work hard to build your credibility. And this is best done if you team up with healthcare providers which have this reputation and the go-to-market channel, right? And then you can, of course, go after it. But then what I'm also witnessing sometimes is people say, it sounds too good to be true. And then we are very transparent. So we show our clinical study data, our quality performance data. But what's fundamentally different for traditional laboratory diagnostics is that we measure the physics of molecules. We don't use color reactions. We don't use enzymatic reactions. We don't have any fluorescent dyes which kind of pop up in the dark. We measure electronic signals of molecules. It's a physical method. And that's why we are capable to operate this in a highly parallel, multiplex, label-free fashion because we use the physics. Now, when I speak to radiologists, they instantly get our concept because radiologists are used to use big electronic equipment to perform a physical measurement and then to use AI-enabled software for interpretation. But when I speak to laboratory clinicians, like the clinical analyzer guys, they are at the beginning very skeptical. They say, oh, how can I do that? Why don't I use just a clinical analyzer? So it takes time to get them on board. But once we show what we do in all detail, then we get them as well. But it takes basically lots of communication to build the market. Also, I don't want that people believe us. I want that they understand what we are doing. That's very important, right? Because there are also some not so good examples from the healthcare industry, from the Silicon Valley, not to mention any names. But then that's why it's so important to basically explain in detail what's going on so that people don't say, oh, it sounds too good to be true, I don't buy it, right? And that's why we're very open.
Oh, no, that's really, really thoughtful. I appreciate the detail. So I guess maybe another kind of poking at go-to-market a little bit. So a lot of, say, employer-sponsored health plans or large employers say, for example, like for them to address sort of obesity or lifestyle, sedentary lifestyle, they'll pay for your gym membership and that kind of thing. So have you had an opportunity to explore that as another go-to-market, large employer-sponsored?
Basically, corporate health programs are a big topic in the US. They're a big topic in Asia Pacific, also in select countries in Europe. That's one of the, I would say, most exciting areas because from a healthcare economic standpoint, these are funds which are not from the common healthcare buckets. They come from different other buckets. And at the same time, low cost structure enables or allows basically quarterly or monthly subscription business, which can be extremely lucrative, right? And that's why I'm more interested in the high frequency, lower margin business because it's more interesting in its overall magnitude. But on the other hand, the healthcare market is, I would say, more cautious than it used to be 20 years ago. So basically, before I go to these insurance companies or corporate health players, I first want to collect real world evidence data, right? The beloved ones. And this is basically something I'm aiming to collect this year. And then to basically take the data, take the packages, and then basically show these impacts for corporate health providers, but also to insurance in general, to show this as an incentive models on the preventive care side.
Yeah, no, I appreciate that. I do think there, it's a really good aspect to consider. It sounds like you really looked at all these angles. The whole idea of shared decision making, kind of data driven, where it's patient centered. I think all that could be part of what you're doing. I think it's exciting to consider. And it's too good to be true objection is a real objection. Like that's a serious, it's everybody thinks, oh, how hard could that be? It's like, it's not, like you said, when you're in the world of this, healthcare, medical world, everybody's kind of very prone to skepticism and change management. And the culture is really predisposed to that, first do no harm, do nothing till you know everything. So I really appreciate that challenge.
Yeah, so what I enjoy a lot is to basically host guests in our company because whoever visits us typically gets blood drawn and then we perform a live demo. So the blood sample is turned into blood serum, 0.5 milliliter. We had our sample buffer, of course proprietary, but then we basically have an automated testing setup. Takes about 5 minutes to scan the blood sample and the processing time takes about 10 minutes. So basically we provide after or at the end of the visit the record and then they can take it, show it to the physicians. Although what I do myself is I use very often the standard checkups offered by standard labs compared with my data obtained with our method at Lifespin. And I'm pleased to see that basically our method can capture more. At the beginning, from a positioning standpoint, it's the classical MBA faster, better, cheaper. So I didn't mention here today the more advanced work we are doing in neurology and oncology, because I first want to put all the attention on preventive care. The reason is all the other topics are a minefield, and you first want to build the credibility before you want to disclose your other activities, which can be extremely interesting in the setting of differential diagnosis of neurological diseases, differential diagnosis in oncology, and monitoring treatment. Actually, one of our next steps after the preventive care market establishment is to go after treatment monitoring, because we all know diagnosis is a minefield, right? To look at many companies, lots of money is being spent, but diagnosis is critical. However, every patient and every physician wants to know, does the treatment which is being applied to the patient actually works, right? Not everyone may want to know this answer, but technically you want to know. And basically, when you look at the response of the metabolome, you can tell quite a bit. So this is just the sneak preview, more to come. But basically, that's not another big issue, another huge market opportunity to unlock lots of monies, basically. But important first is to set the ground in preventive care.
Perfect. Well, thanks. I'll turn it back to you, Greg.
Great. Well, Ali, this has been great. I know it took us a while to finally get you on, but incredibly enlightening conversation. And I think it would be of value to healthcare leaders now who are looking at incorporating personalized medicine as part of some of their outreach programs, especially as they relate to value-based care and population health. Well, for audience members who are not familiar with this, Spyglass Consulting is a product and go-to-market strategy firm focused on disruptive technologies and growth opportunities within the healthcare and life sciences industries. We proudly serve more than 250 leading entities who are a combination of technology companies, management consultancies, healthcare providers, and investment organizations. We've published more than 30 market research reports on a diverse set of topics. To access our library, pay research, and to gain a deeper insight into how technology is reshaping the healthcare industry, I invite you to visit our website at www.spyglass-consulting.com. So before we conclude, what call to action would you offer healthcare leaders to ensure personalized medicine is implemented effectively, ethically, and with impact?
First of all, it should be useful. What frustrates me quite a bit is when I see direct-to-consumer offerings, they're first of all very expensive, right? Several hundreds of dollars. And what you get at the end is a statement like, drink more water, do more exercise, and stop smoking. I don't like that. So basically, the key is, these businesses will not be sticky because people will say, hey, I pay once $500, but I won't do it again, right? And that's why the important question is, that's what we are discussing in the team at Lifespin all the time is, how can we determine the thresholds? How can we set that in a way that it gives you immediate, actionable information that people can do really something about it? So it's not about just having a money-making gig that's boring. Could do other things for that, but the importance for something which is fully useful, which helps you to manage your lifestyle. And what I really like here is the achievement of step counters. Now, when I work at home, I wear my smartwatch because it alerts me all the time when I'm sitting too much, right? And that's wonderful. And then I try to keep up with my walking. Very helpful. And if you have something for your general health status at low cost, that would be amazing. Of course, in healthcare, you always have the challenge that you need blood. That's the only caveat. So and I would also claim to say that there is no deep health insight possible without looking into the blood sample.
Awesome. Lee, thank you. Keith, do you have any final thoughts on today's session?
Well, I just want to thank Ali for sharing this expertise and insight and this kind of exciting technology and the role of, personal prevention, how that could play a role in a lot of the challenges that, he's described really well about, patients kind of being told, just these very high level superficial things that they need to change in their behavior. But yet, this maybe gives them the data and some of the real insights they need to actually want to do something about it. So I think it's really exciting. I'm really looking forward to seeing where this goes, Ali. And love to follow your journey and see how you guys are doing, because I think it's really the idea of it being tech that's useful. I love that premise. That's really helpful.
Thank you.
Great. Thank you, Ali. Thank you, Keith. Thank you for listening to Beyond the Blueprint. Together, we're exploring how thoughtful design can simplify complexity, enhance patient care, and create meaningful change. If you found value in today's episode, make sure to subscribe and leave a review in order to help us continue the conversation. Let's reimagine healthcare together on Beyond the Blueprint.